And next talk is on demystifying the vertical component in horizontal strabismus. Over to Dr. Jisha.
Thank you, madam. Demystifying the vertical deviations in horizontal strabismus. Horizontal strabismus is the most common type of strabismus that we encounter in our clinical practice. But when we evaluate for the ocular movements, we see some vertical deviations which makes it very complicated to understand from the perspective of a general ophthalmologist. So the diagnosis of horizontal strabismus with vertical deviation needs a thorough knowledge on the clinical characteristics of each type. I'll be focusing on the evaluation and diagnosis of vertical deviations only. Management will not be addressed in this class. And the evaluation starts with examining the eye, the movements in 9 cardinal positions of gaze, and assessing for the vertical deviation in each position of gaze and addressing the diagnosing the pattern. And at the end of that evaluation in 9 cardinal positions, first category is forced over evaluation in adduction. In this picture, you can see that the first picture is that of left esotropia. When the child is looking to the right position, you can see the left eye is elevating. That is the over elevation in adduction of left eye. And it is diagnostic of inferior oblique overaction. Inferior oblique overaction is seen in 70% of infantile esotropia. It can be seen in other types of acquired esotropia like accommodative esotropia also. And 30% of cases of exotropia can also have inferior oblique overaction. The other features of inferior oblique overaction are that usually congenital esotropia manifests by 4 to 6 months of age, but inferior oblique overaction is delayed presentation after 1 to 6 years of age only. It is mostly bilateral, though it can be asymmetric. And the horizontal strabismus changes in the pattern of V pattern strabismus, that means more of divergence in upgaze. And the most important factor is that even if you operate the horizontal strabismus for infantile esotropia before the age of 1 year, the inferior oblique overaction can have a later presentation. So better to include that also in your consent form and make the parents aware. There are 2 types of inferior oblique overaction. One is a primary one where there is no associated pathology, it is idiopathic. And the secondary variant is due to paralysis of the same eye, ipsilateral superior oblique paralysis or the contralateral superior rectus paralysis. But the paralysis, the paralytic muscle, it may be difficult to identify because the limitation of movement will be very minimal. So how to identify whether the oblique overaction is a primary one or secondary one? The most important diagnostic test is a head tilt test. The vertical deviation, you have to measure the vertical deviation in the primary position by tilting the head to the right and then to the left. If the deviation is more than 5% diopters, it is diagnostic of a secondary inferior oblique overaction. Of course, you can look for other points also, like the pattern of V pattern. It is sort of Y pattern in a primary inferior oblique overaction and an arrow pattern in secondary inferior oblique overaction. And is it the only diagnosis when the eye is over elevating in adduction? No, you can observe the upshoot of Duane's retraction syndrome, but you have to look for you can diagnose Duane's by other features. And a tight lateral rectus muscle due to a long-standing exotropia or an over-resected muscle also can produce an upshoot in adduction. And sometimes you have to know that a DVD, when you are looking for version movements, the adducting eye may be occluded from the target by means of the nasal bridge, and you will get an overshoot of the adducting eye. That is DVD, not inferior oblique overaction. And a vertical displacement of horizontal recti muscle, especially after surgical procedure, can also can mimic an inferior oblique overaction. And the second set of vertical deviations are over depression in adduction. It is taken as superior oblique overaction. And it is mostly seen in exotropia, but it can occur in esotropia also. And the horizontal strabismus, strabismus can have an A pattern with a divergence in down gaze, mostly lambda type subtype of A pattern. And you have to look for, sometimes you will get an elevation restriction or a limitation of elevation in adduction. That is because of the tight or the overacting superior oblique may limit the eye from moving up in adducted position. This is a pattern. And the next vertical movement that we have to think of is the dissociated vertical deviation. And this is a hypertropia which is not obeying the Herring's law of equal innervation. Either eye, you can see that the either eye is slowly drifting upwards and outwards with a simultaneous extorsion. This happens when one eye is occluded or even during periods of inattention. So this girl is having a divergent squint with dissociated vertical deviation. You can see that the vertical deviation in both the eyes is from above down. Both the eyes are coming from above down. This is unlike the hypertropia where when you are doing an alternate cover test, you will see that one eye is moving from above down, the other eye is moving from below up. That is hypertropia. And this is manifest dissociated vertical deviation where you can see that the left eye is spontaneously drifting up and it is coming back. This is manifest. Whereas in latent DVD, the updrift occurs only when you occlude the eye. The eye undercover drifts up. The other features are it can have head tilt and there will not be any diplopia because of absence of binocular single vision, and it will be bilateral. Most of the time it is bilateral, but it is asymmetric. And it can coexist with oblique overactions. The diagnosis becomes very difficult and complicated when it is coexisting with inferior oblique oblique overactions, either superior or inferior. And that may be the reason for incompetence of the vertical movement that you observe with dissociated vertical deviation. And how to differentiate inferior oblique overaction from dissociated vertical deviation? You have to know that the elevation or the upward movement is seen never in abduction in a case of inferior oblique overaction, where in DVD it occurs in all the positions, primary, adduction and abduction, the vertical movement is happening. And V pattern may be associated with inferior oblique overaction, but it is not a feature of dissociated vertical deviation. And you have to closely observe the refixation movement, which is a sudden movement or a fast movement in inferior oblique overaction, whereas for DVD it is a very slow movement. And you might observe on refixation the encycloduction movement may be observed. And another interesting feature that you have to look for is the Bilchowski's graded density filter bar. That this test can be done when you are in doubt. That means when the you have to keep neutral density, increasing density of neutral density bar in front of the fixing eye. And when the light intensity of the fixing eye has been brought down to a particular level, you can see that the dissociated eye gradually comes down. And the comitant hyperdeviation is a very small angle of comitant hyperdeviation can occur in 25% of horizontal strabismus, which does not have any impact on your surgical management. So the differential diagnosis the differential diagnosis of various conditions in vertical deviations you have to address, because the diagnosis is important to recover both functional and cosmetic outcome. Thank you.
Thank you, Jisha. She has explained the difficult part in strabismus is the vertical component in a simplified